from the Heart of Medicine, and this is my grand rounds I will be presenting tomorrow. I'm just going to rehearse it here, and if it's good enough, I'll share it. If it's okay, I'll also share it. So let's go ahead with it. And just for some context, it's May 22nd, 2025, and without further ado, let's go into it. So I have no conflicts of interest to disclose. And what motivated me to talk about this? So during interview season, while I was deciding how I liked the programs, and the programs were deciding if they liked or disliked me, one of my strongest programs, I'll say my top two programs, cardiology programs for fellowship, the program director said this, and I quote, "I would recommend you to look up today's topic, what I was motivated to talk about, if you are not familiar with it." And I had no idea what he was talking about. I actually wrote it down on a piece of paper, and then I went to look into it, and I was like, this is interesting. And yeah, so that's great. So what other things motivated me? Of course, being in a pretty busy hospital where you have to balance quality over quantity, and also having some interesting interactions. In one of my busiest ICU night shifts, we thought we had an easy admit, because usually the neurology admits that were maybe a stroke or a tumor were quite easy, because you just admitted them, and then next day neurologists will take over and order all these tests. So we thought we had the patient tucked in fairly quickly while we were busy intubating, doing central lines and all that. And guess what? We maybe could have listened to the patient and what the patient actually wanted. So just because the patient had a huge central nervous system tumor didn't mean the patient wished to stay. The patient had capacity, and the patient actually preferred to go home, share with family, be with the patient's dogs, and pass away in that manner. So after we did all the admission, that was the quickest admission and discharge. And then another encounter that I saw a subspecialist say, literally, I saw 99 patients today, and I just thought to myself, is that humanly possible? Like, how is that possible? I'm dumbfounded. I have no idea how that's possible. So those are my main motivators, and we'll get to what the topic is in a moment. You can probably see it down there. But every single lecture I have presented here in the US is bearing in mind that our time is limited. I already went through residency once in Costa Rica, and in Costa Rica I understood that there's only so many talks you can present during your lifespan as a resident. And repeating residency here in internal medicine, I was very aware of that, and right off the bat, every single talk I did, I put in a whole lot of thought into it. I had a Google Docs sheet with all these different topics, probably maybe 100 topics, and in the end, I could just choose so many. So for some examples of these talks, well, basically all involved a common theme. So what is the most impactful thing I can present that might leave the best impact, right? The best outcome that might continue after I'm gone. So one of those talks was the troponin talk. Why? Because with that talk, my main goal was, if you're gonna order a test, make sure to know what to do after you get the results. Just don't order a test because you order a test because you have this clinical suspicion of X, Y, and Z, and you know how to act upon it when it comes back altered. Another one was post-code debriefing. So in our hospital, I've seen a lack of debriefing post-code, and this happens all over the world. And yeah, if communication isn't happening after a patient dies, and we don't understand how we can improve next time this happens, how are we even communicating with the small things and minor things? So let's start communicating, which is so important. Then I talked about the importance of prevention. You want to prevent the problem before it happens. So type 3 diabetes, now known as, well, Alzheimer's, now sometimes thought of as type 3 diabetes as well. So with that talk, it's, if you can control diabetes, you can probably avoid many cases of Alzheimer's. Not all of them, right? There's some that are genetically imprinted on you, but you can probably avoid many. And as you know, once you have a diagnosis of Alzheimer's, usually it's not mild disease. Usually it's moderate to severe, and medications and every therapy, when it's in those stages, will do almost nothing. So today's talk will be about Schwartz rounds. So I'll still leave you with the doubt, because I know most of you have never heard about the word Schwartz in medicine. Probably many of you have associated it with the Schwartz surgery book, but it's not this, it's something else. And now I'm gonna maintain the suspense a little longer. So let's just go to this question, multiple choice question. I highlighted it for you, and I just want you to think it through. This is a 62-year-old male, failure to thrive, has decreased food intake and weight loss over the past 2 to 3 months. Most of the day is just bedbound, is dependent on most activities of daily living. A CT of the chest, abdomen, pelvis is showing you numerous hepatic metastasis with biliary ductal dilation and no other abnormality. So there's also acidic fluid showing you there's poorly differentiated adenocarcinoma. So what is the most appropriate management? So I'll give you a couple seconds for you to think about it. Well, you can pause the video, and now we're back. So the answer for this is actually supportive management and hospice care. So maybe it's an easy choice, right? Because this patient's functional status is pretty bad. The cancer is irresectable, it's incurable. So yes, it's gonna be hospice care. So you know the medicine, but do you actually know how to go and communicate this to the patient? So that takes me to the importance of Schwartz rounds, which a main theme, or the main word that powers what it comes to be known as Schwartz rounds, is the word compassion. And this is an extremely strong word that I want you to always have in your dictionary. And if you feel you're acting with compassion, like, cheers to you. That's a sign of a great professional. Why? Because it's a strong feeling of feeling sympathy, sometimes empathy, and sadness for the suffering or bad luck of others. But that's not it. It's followed by a verb. It's followed by a wish to help them. It's followed by action. So that's the importance of compassion. And maybe Schwartz rounds can increase that. So we'll see that next. So then I went to review one of the main sources we have to study medicine and internal medicine and most residencies across the United States, the American College of Physicians, MCAP, MEXAP, which we usually call, and I searched the entire library with the word Schwartz. There's no mention about these rounds. There's zero results. But if you go and you look for example, that patient I just told you about, hospice, yes, you're going to get several multiple choice questions that tells you that that's an easy answer. Well, how will you convey this information? Well, there's zero results here. So maybe this is just showing us how systematically we are not being trained in a very important sphere in medicine, which is also thinking about how to convey information, how to work with the patient after you actually have a clinical decision making, and all the other things that factor in the patient physician-patient relation. So you probably won't be able to listen to this clip I have right here, but I'll just walk you through it. And this doctor is basically telling this family, this is from Arrested Development, it's pretty funny, I would recommend you to look it up, but this doctor is telling the family that the patient looks dead. He just says, patient looks dead, and the family has already had bad experiences with this doctor, and they're just confirming, hey, hey, what do you mean by actually looks dead? Is he actually dead or what's going on? And the doctor tells them that no, he just looks dead because he has blue paint on himself. And then the family sort of gets pretty frustrated and angry, which is of course a normal response. But things like this, probably not maybe to this extent, do happen in hospitals because we don't have training on how to communicate things sometimes. We don't have training in empathy. We don't have training in, if you haven't lived it, in sympathy. So we're trying to avoid those things from happening. Okay, so look at this image right here. So then we ask ourselves why these other things happen. So if there's compassion, there's also compassion fatigue. There's also gaslighting, which goes on, etc., etc. And all of these things end up in this little ladder, which happens worldwide. I've already been in 2 different continents and practiced medicine in different places, and I've seen that this is, on average, the issue. So where do you think the intern will be in this ladder? Where do you think the resident is going to be? Where do you think the attendant is going to be? Yeah, you don't have to be a genius to know that. Here you have your interns, here you have your resident, here you have your fellow, and this is the attendant, okay? So yeah, should there be a hierarchy? Yes, I do agree. But should there be all this white stuff falling off from the top? Probably not, right? So it's also a systematic thing, and depending on the environment you're in, you're going to get a little bit more or a little bit less of this white gooish substance. And also remember that suicide remains the leading cause of death among medical residents. And you always have to finish that with study finds, right? Well, this is a little bit of selection bias because most medical residents will be in between their 20s, 30s, and of course the chronic comorbidities or cancer won't be that high regarding cause of death. But it's interesting that this is above trauma, for example. It should be trauma, it should be accidents, motor vehicle accidents, but it's not happening. So we have to also think about ourselves. So let's talk about what health is for a brief moment. So we are not only the flesh. So sometimes we forget about it. That's why we're going to all these conferences, noon conferences, and we're always talking about the flesh. We're always talking about the physical well-being of the patient. But we seldomly remember the World Health Organization description and definition of what health is. It's not only physical, it's also mental and social well-being. And look at this, not merely the absence of disease or infirmity. Okay, so now that we know that health is more, I think that now we're understanding why this talk is probably important for us, because it's not only us that are involved, it's all of us. So by saying the word we, who are we? So we are the resident, we are the intern, we are the patient, we are the family member of the patient, or 2 patients here, and we are all the staff. We work as a team. So that's how you build rapport with your patient. You're part of the team. The patient is the protagonist, but you also play an important role. So we all have to be sort of well, right? And we would expect that for you to be able to help the patient, you should be well yourself. So it's not just saying, hey, you have to be well because you're a doctor. No, you also have to have the tools to feel well enough. So all these pictures right here are HIPAA compliant. As you can see, they were taken. This one is 2017 while I was doing medical residency in Costa Rica. I think I was a PGY2 right over here presenting a patient. And this patient was fond of what we were doing. So he took the picture and then he shared it with us. So here I am with the whole team of hematology, oncology. And these other patients, this patient was having his birthday that day, so I brought him a little cake. These patients were my nephrology patients, which were on chronic dialysis. So yeah, I had all these good relationships, which that's what I tried to nurture. And the way I can nurture this is by being healthy myself in all these different spheres. So that is what I want to promote for whoever's watching this. Let's promote the well-being of the team. Let's promote a good environment. Just going into a hospital and saying this is a good place, like I love this place, and not being like, oh, I have to go to that hospital again, right? That's just bad. So now let's delve into Schwartz Rounds specifically. How did it originate? So the word Schwartz is the last name of Mr. Kenneth B. Schwartz. And Mr. Kenneth Schwartz was not a doctor. He was not related to the medical field, but he was a healthcare lawyer. And all of a sudden, after he had his child, he was married, he started having constitutional symptoms. And in November 7th, 1994, and this is what he writes, he wrote this in the Boston Globe magazine. He says, when at age 40, I was diagnosed with advanced lung cancer. In the months that followed, I was subjected to chemotherapy, radiation, surgery, and news of all kinds, most of it bad. It has been a harrowing experience for me. And basically, he says, harrowing experience for me and my family. And yet, the ordeal has been punctuated by moments of exquisite compassion. There's your word. I have been the recipient of an extraordinary array of human and humane, not only human, humane responses to my plight. So here you can see this great quote. He says, these acts of kindness, the simple human touch from my caregivers, have made the unbearable bearable. How strong is this? Just think about it for a moment. Just think about the difficulties he could have been experiencing going through advanced lung cancer, which has nowadays, it has a mortality. It is number one in mortality, and has more mortality. It ends the lives of more people than the next three most common cancers out there. So imagine going through that and being able to say, well, I'm seeing light at the end of the tunnel, and I appreciate the way these people have taken care of me. So that's something I want you guys never to forget, that even if the patient is in their last moments, sometimes we can make a change. Sometimes we can promote a little bit improvement in their quality of life, even if they have some hours to go. So I have a quick example of this. When I was in Costa Rica, there was a patient that had aortic dissection, and the patient, it was expanding very quickly, and the patient was actively hemorrhaging into the abdomen. And instead of focusing on trying to take the patient to surgery, the patient was given a chance to decide if they wanted to try to be rushed to surgery or speak with their family, because the patient had some minutes left. The patient chose to speak to family. The patient was able to say goodbye. And at the end, his wife was so thankful that happened. The patient ended up passing away, and this was something that probably was going to be unsurvivable. So they still tried to rush him to the OR, but they did think about what were his last wishes, because that was that moment in time. So that was putting themselves, because I was just an observer, in the patient's shoes and trying to help. So how are Schwartz rounds structured? So here you can see a lot of people sitting down in these rounds. It's like a regular, let's say a regular noon conference. Usually food is provided. That's always recommended for the Schwartz rounds. And actually Kenneth B. Schwartz was able to found this not-for-profit organization to promote the rounds before his death. And after that, I think his wife has done a great deal to continue working on it. And then the Point of Care Foundation, which I believe is from the UK, continues to work on it. So it has expanded worldwide. And I believe it's time to share it with you guys. So it's usually panel presentation, 15 to 20 minutes, 3 to 4 persons of the staff share experiences. It is led by the facilitator, and there's sometimes an open forum. People can be vulnerable here, share their experiences. What are the cases that you talk about? Well, you focus on the social and emotional aspects of care. You're not talking about hypercalcemia, and I had a tough time with this. The PTH was negative, and then the PTH RP was negative, and then the 125 dihydroxyvitamin D was elevated. No, that we already know that. We already know that that's always going to happen in the hospitals. Let's focus now a little bit more on important aspects such as social and emotional. Like what? Like the patient that always comes in, the sickle cell patient, that it's always so people have difficulty because as soon as they come in, this patient comes in and sets their things, their laptop, their pencils, this and that, and the doctors are ready to discharge the patient, but the patient is like, no, not today, tomorrow. The next day comes and the same thing happens, and that over and over. This might be a situation that maybe you want to bring up to this forum and say like, I don't know how I can actually. I'm not sure if I'm empathizing with the patient or is it me or this or that. So people speak out, and that's the idea. It's for you to be able to understand yourself better. People understand that they're not alone, and all these things have certain goals, which we will see in a moment. So usually, as I said, there's different roles: the facilitator, the clinical leader, a planning committee, and an executive sponsor. Okay, then this is a very nice chart, which I want to basically go through it real quick, just so we understand how all these things can generate stress. So sometimes there's organizational and cultural factors, including workload, that generate some stress. There is also concerns with your colleagues that you might not feel support or altered trust. That is also associated. The level of support from those above you. So in this case would be the program leadership, right? Or what about if you're working in emotional labor sort of thing, that can also increase the burden. And there's personal factors, which are going to be your own psychosocial history, personality, etc. So all these things can generate stress. But the thing is, how can we work on this? So then we can go down to this little side which says threat and anxiety trigger inward focus. This reduces compassion and empathy for others. And probably all of us seeing this video probably can understand it. I'd say that if you've been in medicine long enough, there's been that day that you were planning on heading home like early or on time, and all of a sudden it was maybe like 8 p.m. and you're still in the hospital. And when you're walking out, someone comes and asks you like, hey, can you tell me about my labs or this or that? Depending on how affected you are from all these other things, your answer could be bad, right? Could be a bad answer. So that's the importance of attending the Schwartz rounds. The Schwartz rounds will help you be vulnerable, share these social, emotional interactions, and it will help prevent or arrest the vicious cycle that can culminate in withdrawal from patients and restores a protective sense of collectiveness with colleagues. So some of the main goals from the Schwartz rounds in general are to enhance communication and empathy, support staff and patient well-being, promote compassionate care, and build confidence in difficult situations. Of course, this is not an EBM lecture, but just to mention it briefly, I have the pyramid we always see on the EBMs, and in this case, you can see that most of the evidence is not that high, so most of them are cohorts, and that's reasonable because if you're trying to evaluate how response on is an intervention that is going to rounds with your own like willingness, you cannot make this a randomized controlled trial because there's no blinding. You either want to go or you don't want to go. So it's almost impossible to do a full-fledged RCT on this. And I would say that probably most studies are already showing positive results. So probably we don't need a real RCT here, and probably it wouldn't be even plausible. So, of course, I'm just going to mention some limitations of most of these cohort studies is that there's going to be the response bias. Most of the responses will be through surveys, and that's the measure of how effective or not the Schwartz rounds are. So, yes, it's going to be limited. I do understand maybe there could be a way that you could see a signal or an effect without a survey. Maybe you can do the Schwartz rounds and see patients' outcomes or specify a specific marker such as sick days from staff, for example. That could be one, and indirectly that could be not a survey, but actually something a little more objective. But yeah, it is what it is. So most of these are prone to response bias. Of course, that is also prone to the Hawthorne effect, which is altering a response on a survey just because you know you're being observed. So if you know, oh, they're trying to sponsor this, I just want to rate it highly because I know they put a lot of effort, that's going to be Hawthorne effect, right? That can happen. Most of these cohorts have no control group. Most of the respondents are not medical residents, and most of them have already more than 10 years experience in the field, be it nurses, be it ancillary staff. So well, it might not be so applicable for residents, at least based on the evidence or the lack of evidence. But that's what we have. And of course, several of these studies, mainly in the United States, have been funded or supported by the Kenneth B. Schwartz Center, which is also some sort of conflict of interest, but just important to mention. But other than those limitations, even in the absence of studies, if we just think it through, there are some things that just make sense, and probably talking about these issues makes a lot of sense. So I'll just show you some questions from these surveys. And as you can see right here, I put a little light bulb. So these are important questions that many people never ask themselves, and this just opens your mind into thinking, hey, can I improve this? Can I improve that? So this first section is the patient interaction scale, and you can see that here you see, I am comfortable discussing tough and sensitive non-clinical issues with patients and their families. I have sufficient ideas or strategies for handling patient situations. I have compassion or sharing in the suffering of others for patients and families. I feel energized about my work with patients. And I'll now go down to teamwork scale. So some questions about teamwork. I appreciate the roles and contributions of teamwork. I have good communication with colleagues or teamwork personnel, the team. I am open to expressing thoughts, questions, feelings, and about patient care with colleagues, and I am willing to offer support or to receive support from a colleague. So these are eye-opening questions, and of course it requires some level of vulnerability to be able to answer. But whenever we feel free to be vulnerable and answer these questions, it usually is for the good, right? It usually is followed by positive things. And just to show you some positive findings, so this was analyzed with ANOVA, so analysis of variance, and you can see that infrequent let's see, people who went infrequently to Schwartz rounds versus those who went frequently basically showed a statistical significant difference that benefited those that went frequently. So in summary, those that went frequently had better responses or a better rating on a scale from 1 to 5 regarding these questions. For example, I have more compassion for patients and families. I feel more energized about my work. I have new strategies for handling patient situations. So all those things are positive. How much will that actually relate into real world? Tough to tell, but there are some indirect signals which are very good. For example, here you can see that in this survey, about 50% of those survey respondents mentioned that they observed changes in practices or policies within their departments or institutions since the initiation of rounds. So that's pretty a strong signal, right? Also regarding teamwork, this was a very strong response with a inclination towards improvement with attendance to the Schwartz rounds, which was the appreciation of the roles and contributions of colleagues from other disciplines. So appreciation, of course, will be important whenever you're working with a team. So this other study right over here done in the UK was one of the longest ones with a 6-year follow-up. And what I want to note is that the signal remained. So the good results from the rounds was persistent or consistent throughout the entire 6 years, and that is why the NHS ended up funding a whole lot more of centers to start doing the Schwartz rounds. So you know that whenever a big entity, healthcare entity, will fund something, it's because there's some sort of benefit. And yeah, these are showing a good signal, so that's why I guess they funded it. So this is another study just showing you how this study was a pre-post quasi-experimental evaluation. So they wanted to do something near or similar to an RCT, so they did an intervention arm, which people were approached at rounds, and they did a control arm, which these people just received an online survey. But the main thing I want to show you here is how difficult it is to maintain a sample size when you're going to something that, it's just you're going to rounds, you have difficulties at work because you might be busy one day, you might have a whole lot of tasks, and as we advance in this day and age, the workload is not becoming less, it's usually becoming more. So as you can see here, this number went from 514 to 41 of the active intervention arm, which are those that actively participated with rounds and kept going to the rounds. And this control group that didn't even go to the rounds, were just answering the surveys without going, the number went down from 680 to 233. But even with that, even with this sample size, there was a signal, and the signal was mainly with reduction in psychological distress. So look at these bars. These are the frequent attenders or the attenders through the rounds, and these are non-attenders. Look at this drop. So first of all, yes, there is a little bit of bias. So you can see that those attenders from the start at baseline already had less psychological distress than the non-attenders. So you can say off the bat that people that were attending the rounds from the start, probably they had certain reasons to go to these rounds and probably already had more psychological tools to manage stress, because at baseline they were already less distressed. And the most important thing here to see is the drop. So it went from 25% to about 12% in the attenders, and the non-attenders, very minimal drop in their stress or distress levels, from about 37% to about 34%. So that was shown mainly through the GHQ questionnaire, which is a very good questionnaire. I hadn't heard about it in the past, but this is a good questionnaire, and I'll show you what it encompasses. So the GHQ is the General Health Questionnaire. It takes into account 12 different things. Here you can see, and all of these, of course, will tell you about your psychological distress. I believe everyone should do this and check how distressed or not you are, and you can do it yourself, and you can look it up online, and it'll see your ability to concentrate, if you lost sleep over worry, if you feel you're playing a useful part in what you're doing, capable of making decisions, etc., etc. So I would recommend you to have a baseline, because remember, just because we are doctors doesn't mean that we cure ourselves, okay? So you might need help, so check this out. And this is my proposed new noon conference schedule. Here you see the robot. So we started the lecture off with the robot. Here the robot is becoming more human. So what differed or made a robot different from a human in the past, and I guess still today, until who knows what happens in the future, but it is that lack of feeling of emotion, of empathy, of compassion. So yes, we want to work on all those things and work on psychological distress, which robots do not have. We want to be more human, and the way we do that in our healthier is going to be having not only these lectures, not only these noon conferences, but maybe substituting one conference, not adding, because if we add a new conference, it's gonna be problems, right? Because we already have enough conferences. Just replacing one conference probably every 2 weeks, every month for a Schwartz Rounds. And the key takeaways, of course, is to not ignore the elephant in the room. And we already talked about some of these things over here. In this hospital, we have a very good ombudsman, Mr. Templeton. He rocks. Look him up if necessary. There's also the possibility of EAP coaching, so you can ask program leadership if necessary. And I think EAP stood for Emotional Assistance Program, if I'm not incorrect. And I already mentioned this. And if you wish to increase consciousness about this topic, let me know. I said I will mention I have a shareable link, which is probably this video you're seeing right over here. And here you have a picture of Mr. Schwartz, his son, and his wife. And yeah, this is his legacy, and incredible to be able to power through this while having advanced metastatic lung cancer. And my references are right over here. If you want to go through any of them, I'm just gonna leave them right there. Thank you for your time, and give me any feedback, comments, opinions, and see you in the next one.